So we want to look at syndrome of inappropriate ADH secretion, which is an important endocrine disorder that affects, that occurs as a result of a problem in the posterior pituitary, basically in the production of vasopressin, or what we know as antidiuretic hormone. So as an introduction, the syndrome basically is characterized by excessive secretion of antidiuretic hormone, and that's why we are calling it syndrome of inappropriate ADH secretion. Basically, we are having more than we require. So we already know that vasopressin is produced from the posterior pituitary, or actually it's just stored there, but the production is from the hypothalamus. So ADH as a hormone is important for controlling water reabsorption, and this happens at the nephrons in the kidney. So this helps basically in retention of water. So if we end up having excessive production of ADH, basically we mean that we end up having a lot of retention of water, therefore causing hemodilution and also dilution of sodium in our body. So the normal physiology, I think we've already basically looked at it in a nutshell. What we mean is that vasopressin, which is produced in the hypothalamus, but just stored in the pituitary, what it does is it is released and it travels to the kidney and then goes to the nephron, where it binds to receptors that causes the opening of what we call the aquaporin 2 channels. These channels are very important in enabling a movement of water back into the bloodstream. However, that is the only thing that it does. It doesn't also help the reabsorption of, for example, sodium. So what happens is that we end up just reabsorbing water alone, and the sodium that we have in blood remains constant. So what happens is we hemodilute, or basically we dilute the solutes that are there like sodium, and we end up having dilution of the hyponatremia, or lower levels of concentration of sodium. So as a result, there is a decreased volume of urine, and also there's increased osmolality, or basically the concentration of urine is more, and it's concentrated, and it has a lot of the solutes because there's no water to dilute it as it is coming out. So we have urine concentration that is increased osmolality, and we have decreased volume, or basically oliguria, because most of the water that would have come out as urine is being reabsorbed. So the extra water that has been reabsorbed re-enters the circulation, and then it ends up diluting your blood. So the serum concentration or the serum osmolality goes down. Okay, so it is not so much concentrated because now it's diluted by the excess water we are taking in. So this reduction in serum osmolality is normally detected by the hypothalamus, and this will result in decreased production. So there's a negative feedback mechanism that is sent from the hypothalamus. Therefore, now we have less production of ADH and less secretion of it from the posterior pituitary, and therefore that will mean less retention, and then we lose the water. Okay, so the physiology is balanced by the negative feedback mechanism that is sent back to the hypothalamus. But now in the pathophysiology, basically what happens is that this negative feedback mechanism doesn't work anymore, and as a vicious cycle that continues. So instead of sending a negative feedback to tell the body not to produce more, so we end up having more and more continuous production of ADH. Ultimately, that will mean we have more water retention, we have more dilution of the sodium and the serum, and we have less production of urine. Basically, we have less urine being produced, and the one that is being produced is so much concentrated. But the hallmark of this pathophysiology basically is we end up having dilution of sodium, and we have what we call the dilution or the hyponatremia, and we have less urine being produced. Okay, so some of the certain things that will cause this effect to occur, or basically the ADH to keep on being produced and produced and produced. So things like brain injury. So we know the location of the hypothalamus and also where the pituitary is. So some brain injuries from like an infection like meningitis or subarachnoid hemorrhage might tamper with the production of ADH, and we have more of it being produced. Malignancies like small cell cancers, lung cancer, they can also lead to more and more ADH being produced and no feedback mechanism being realized. Some drugs, especially like mental health drugs, like carbamazepine, some SSRIs, and amitriptyline. These are drugs that could also affect production of ADH. Some infection like typical pneumonia or cerebral abscesses, and also hypothyroidism has also been linked to excessive production of ADH. So in terms of the features, we have already mentioned we will end up having dilutional hyponatremia, and we know how the excessive retention of water will lead to a lot of fluid in our body, therefore having hypervolemia, which might cause pulmonary edema and edema in other places, and also things like jugular venous pressure, and you might see that kind of bulging, or the jugular venous pressure going high, and we have ascites might occur also. All this is a result of retention of a lot of water. Then we'll have concentrated urine, we know this, and it will be very little urine. We have oliguria. Also, this kind of mismatch on the amount of water we're taking, the dilution of sodium, that might lead to things like decreased level of consciousness. And then we have cognitive impairment might occur, and also brainstem herniation, which might result to coma and respiratory arrest. So in terms of the test that can be done for this, it's quite simple, obviously. So just history, first of all, a physical exam can point out to this problem, but things like lab tests such as, or chemistry tests such as looking at sodium levels in serum, we expect to have low. In this case, this will point out to dilutional hyponatremia. So when you have like less than 130, or if we have plasma osmolality, basically the concentration is reduced in syndrome of inappropriate ADH secretion. Then also if we have raised osmolality of urine, so urine is concentrated, that can point out. So things like specific gravity of urine might be high, and that might point out to concentrated urine. Also some imaging tests that might show like those kinds of malignancies, or if we have a problem in the hypothalamus or the pituitary. So management is quite straightforward based on the signs and symptoms. So restricting fluid intake, and we know because we're already retaining more, so we don't want to keep on taking more and aggravate the situation. Use of diuretics such as furosemide, which might help us remove some of the water, but closely monitoring of the fluid input output chart and daily weighing. These are very important things that we do for monitoring fluid. Urine and blood chemistry is important, but also you might find that people are given also additional of food that is at least higher in sodium, or increasing sodium intake to try and counteract the action of hyponatremia. So thank you so much.